Good evening, everyone. Sorry to pull you away from March Madness. Had a patient tell me it's the four greatest days of sports TV in the year. Starts at 8 in the morning and goes till 11 at night. It's been an exciting day. Tonight, I'm going to try to just kind of give you an overview of what stem cells are, how they work, kind of where we use them, um, who's a good candidate, who's not a good candidate, a little bit about myself. Been practicing 35 years here in the Seattle area. Founder and president of Seattle Sports Regenerative Medicine. I was a senior partner and medical director of the Sports Medicine Clinic. Was at University of Washington for many years, consulting team for the team position for the Mariners, fellow of the American Academy, and a diplomat of the American Board of Family Practice. So I'm going to go over each of these in a lot more detail, but basically, if we start bottom left corner, synovitis is just all that means is inflammation in a joint. And oftentimes I will just do platelets for that because I'm not necessarily trying to regenerate any tissue. Um, Osteochondral defects, these are little kind of almost like the beginning of osteoarthritis, but they're more in kind of a focal area. Osteoarthritis obviously is probably the biggest portion of our patient population. Meniscus tears, labrum tears. Now, labrum is basically the meniscus of the shoulder and the hip. Except got a little bit of a different anatomy. It's almost more like a gasket. Partial ACL tears, rotator cuff tears, chondromalacia, and that's where you start to get damage in that Teflon covering of the joint, but it doesn't actually extend all the way down to the bone yet. And then tendon injuries, and this is tendon tears, tendonitis, tendinosis that we treat. Okay, probably the largest percentage of patients that we see is for osteoarthritis. Um, Knees, ankles, hips, shoulders, wrists, elbows. This is actually a patient I saw about 5 months ago. Saw her back after 10 years. These were her x-rays 10 years ago when she was told she had to have a total knee replacement, and she just was not willing to do that because she's fairly young. We did stem cells. I told her she had pretty bad looking knees, but she did not want to have knee replacement because ultimately at her age, she probably would have had to have it redone 2 or 3 times. Um, she came back to see me for something else, and she states her knees are still doing great. It's been 10 years now. So we see osteoarthritis in a lot of different areas. We see it in the small bones, in the midfoot as well as places like, the ankle, the knees, obviously, the shoulders, um, base of the thumbs, little joints in the wrist. We see quite often sacroiliac joints, kind of in the glutes, kind of on either side of the sacrum. This was a patient who had a basketball player who had had trauma to his midfoot, and you can see he's got these bone spurs and some arthritis in this called the talonavicular joint, which we did him, and it's been a couple of years ago, but he's still playing recreational basketball. I mean, he's in his 40s. So then we move on to osteochondral defects. So osteochondral defects are kind of one focal area of the bone. Where we see them most commonly is knees and ankles. We also do see them in elbows. They're in usually young, healthy patients. Somebody maybe had an ankle sprain, 3, 4 months ago, and they said, doggone it, this thing's just not getting better. Or they've had this chronic pain in their knee or ankle, and they're only like, 20 in their 20s or 30s or whatever. And oftentimes we'll see these on an x-ray, but sometimes they necessitate having to get an MRI to be able to see them. And these respond really, really well. to biologics. We can get those areas to heal in with new articular cartilage. The meniscus, these are the kind of shock absorbers, stabilizers on both sides of the knee. The medial and the lateral meniscus very commonly torn. We used to have to go in and take out the meniscus, because the meniscus has no blood supply. But now we are healing meniscus tears with stem cells because basically what we're doing is we're putting a blood supply there, billions of cells that can just regenerate cartilage. Now, the only time I don't recommend doing stem cells for meniscus tears is if somebody has something called a bucket handle tear. And that's where part of the meniscus is torn and it flips back and forth and causes the knee to lock. In that case, we have to surgically go in and take out the handle. And then sometimes I'll do stem cells afterwards in those patients. Labrum. Now this is that kind of I think of the labrum in the hip, which this is the hip, and also the shoulder as like a ring of Saturn that goes around the joint. It lends stability to the joint. Once again, it does not have a blood supply. So if you're going to try to repair them in the shoulder, you have to either trim them up or staple them down. And then there's all the potential complications with postoperative stiffness. In the hip, it's a very, very tough joint to get into to deal with labrum tears in anybody over the age of 40. So most of the time, the surgeons will just say, just wait till it's bad enough and have a total hip replacement. Partial ACL tears. I actually see a lot of these. Just saw one today of somebody who had her ACL reconstructed about 15 years ago. And now she's got not only osteoarthritis in the knee joint, which happens to pretty much everybody who has an ACL reconstruction, but she also has a partial tear in her ACL. Stem cells work really well for partial tears. I have actually treated 4 complete ACL tears in patients who absolutely refused to have the surgery and who understood that there was a risk that the stem cells wouldn't bridge the gap and heal the ACL. 2 of these people they're women MMA fighters, and one is a silver medalist Nordic skier from Norway. And they're doing fantastic with healing of their ACL. But I still haven't seen enough data to recommend doing ACLs other than surgically, unless somebody absolutely understands that there's a risk that it might not heal and just does not want to do the surgery. So this is basically an ACL tear. If you see where my arrow goes, we should see this structure right down here, this kind of gray structure. This is part of the ACL, and then you kind of lose it, and it just becomes indistinct through here. And this is where it's torn. The reason I think that if people have a complete tear of the ACL, if there's anything left there, just any fibers, that they almost act as a blueprint for those stem cells. And that's how I think, they can basically heal even with near complete tears. Rotator cuff tears. Now, if somebody comes and they have an injury, a fall, and they land on an outstretched hand, and they all of a sudden they get up and they go, that's as far as I can lift my arm up. That's a surgical issue. We have to sew those back together because once again, stem cells are not going to bridge that gap. However, partial tears in rotator cuff respond better to biologics than they do surgically because the area where the tendons tear is called the avascular zone, and it's a really poor blood supply. That's why they tear at this fulcrum portion of the joint. Well, if you go in and you put a bunch of sutures in there, you compromise the blood supply even more, and 60 to 90% of those surgeries fail within 5 years. And then there's also issues with postoperative stiffness and loss of range of motion, after the surgical procedure itself. Chondromalacia. This is when, and most commonly we see this behind the kneecap. And we see it in runners all the time. And it's because the kneecap needs to track in a groove. And if the tracking is off, then you start to damage the cartilage on the back side of the kneecap. Very common in runners and responds incredibly well to biologics, to stem cells. Tendon injuries, I actually do quite a few partial Achilles tendons, patellar tendons with bone marrow aspirate. I don't put fat into tendons, and we'll talk about that a little bit later. But other tendons that we treat oftentimes, tennis elbow, golfer's elbow, runner's knee, Achilles tendonitis, or Achilles partial tears. Most of the time for the tendonitis issues that we see in golfers and tennis elbow, we treat with platelets because we're just trying to decrease inflammation. We're not necessarily trying to regenerate tissue. However, if we end up doing an MRI on these tendons and we do see tearing or partial tear, then oftentimes we'll put bone marrow aspirate because there we're trying to actually regenerate tendon. Okay, this was an Achilles tendon tear, and let's see, I've lost my marker here. You can see the muscle and tendon coming down here, and then all of a sudden you kind of lose it in through here. There were still some fibers attached in this Achilles. This is a guy who was a former tennis pro and instructor. He's actually this guy has had 8 different joints done with stem cells, and he has done phenomenally well with all of them. And then we did his Achilles tendon, and he golfs, I don't know how many days a year. He's very active wildlife photographer and just doing wonderfully with this. Synovitis, we talked about this at the very beginning. It just means the synovium is kind of this feathery tissue that lines the joint, and it gets inflamed for whatever reason. And in those cases, if I don't see anything going on in the joint, as far as meniscus, osteoarthritis, things like that, I treat these just with platelets, and they usually do great. All right, so what is regenerative medicine? And it's the field of study that utilizes stem cells to heal and regenerate damaged tissue. I myself, in this office, all we do is we use autologous stem cells. That means stem cells from your own body. And those stem cells can only regenerate muscle, tendon, cartilage, and bone. The stem cell it's an unspecialized cell or an undifferentiated cell that's in the bone marrow and in the fat that can basically grow up to be many different things. There's many different types of stem cells, but we only want this one. It's called an adult mesenchymal stem cell. And by virtue of a very complex software program that runs our centrifuge, we're able to isolate those cells in billions. Okay, so this is just a quick kind of, I think it's like a 4-minute little cartoon that tells you a lot about stem cells. And I'm gonna.
What is stem cell therapy? Stem cell therapy is an injection treatment designed to heal injuries and reduce pain. It is used for arthritis and injuries to ligaments, tendons, muscles, cartilage, and bone. First, let's look at the difference between human embryonic stem cells and adult stem cells. The embryonic stem cells are pluripotent, meaning that they can become of any of the more than 200 known differentiated cell types of the human body. On the other hand, adult stem cells are multipotent, meaning that they can develop into more than one cell type, but are more limited and controlled, and thus safer than pluripotent cells. We perform the adult stem cell treatment. What is the role of these stem cells? To understand this better, let's look at this example. Your house is exposed to different elements, such as wind, fire, rain, sun, and time. All cause damage to the structure. To keep your house in order and repair any damage, you need different professionals like firefighters, construction workers, insurance agents, and a contractor to supervise and direct the project. This is no different than your personal life. You need a dentist, lawyer, financial advisor, doctors, insurance agent, and a barber, along with other professionals. So, both your house and your life require different professionals and specialists to keep them working well. And your body needs stem cells. Now, let's dive deeper and see what happens to your joints. In a normal healthy joint, you have plenty of stem cells. These cells are not only capable of doing maintenance and repairs, they also know when and where these repairs are needed. The stem cells work as a contractor that, in addition to giving instruction for repairs and maintenance, can transform into specialized cells to do whatever is needed to fix any problem. When you have enough of these stem cells, there's a balance between damage and repair, and you have no pain and no injuries. Think about when you were 18 years old. You were able to run, jump, and do the same the next day without pain. The only problem is that with time, the number of these stem cells goes down, or sometimes the severity of the injury or damage is more than the ability of your body to repair it. This leads to an imbalance and ultimately leads to arthritis, injuries, and pain. In essence, as you age, you have a lower number of contractors and workers available to do the job, or sometimes the amount of damage is too much for the available stem cells. But fortunately, there are areas of your body that keep a good number of stem cells. These areas include the bone around the hips, the fat in your abdomen and buttocks. And this is the key to stem cell therapy. The doctor will take stem cells from one or both of these areas and transfer them to the area of injury or arthritis. This will provide the stem cells needed for repair. In essence, the treatment will supply the manpower needed to do the job. Once there, these cells secrete growth factors that will organize and coordinate other cells to do the repairs. This leads to healing. This is like the contractor giving instructions to get the job done. This treatment can be used for pain with injuries coming from ligaments, tendons, muscles, bones, cartilage, and meniscus. When is it useful? If you have an injury or an arthritic condition that did not improve with therapy, medication, other injections, or surgery, or if you were told you need surgery, then stem cells is a great option for you. Thanks for watching.
Sorry about that. So when we were 10 years old, there were like 2 million stem cells circulating around in your bloodstream at any moment. When you hit 60, you're down into the hundreds of thousands. So as we get older, the stem cells themselves are still fine. Like if I compare, a 70, 80-year-old stem cells to somebody who is, 25 or 30, the stem cells themselves are the same. It's just that the younger, bigger individuals have more stem cells. But by virtue of this program that we use that was developed by a buddy of mine who ran the molecular biology department at University of California, enables us to get such high numbers of stem cells and platelets also from the PRP that even in patients who are in their 80s and 90s, we're getting 1 billion, 2 billion of those. I have 2 patients that are 103. One came in and we did her hips. She was so thrilled with her results, she brought her friend in who also needed to have hips done, and we done her as well. That's the oldest we've done, and I think the youngest we've done is probably 12, 13, not with stem cells, but with PRP. So the areas where we get stem cells, we get it from bone marrow. You can get it from anywhere in the bone marrow. It's just that the easiest place is to get it from what's called the posterior superior iliac crest. Now, the posterior superior iliac crest, you have your spine that comes down the middle, and then on both sides of it are the top of your pelvis, and that's where we go to those bones right there. We numb up, go down to the bone. I use this specialized little needle, and I kind of drill into the bone. It's not an electric drill. I'm not using a Makita drill or anything, but I kind of go into the bone and then withdraw the stem cells. And it sounds pretty horrible, but it's not that bad. And basically I've done over 20,000 of these, and it takes me less than a minute to do a bone marrow aspiration. So if, literally 50% of the patients who have it done turn around and go, you kidding? You're done already? And the other 50% are like, oh shit, that really hurts. It feels like sciatic nerve pain going on my leg, or it feels like a deep vacuum or hollow pocket. But if you're in that 50%, it lasts about 30 seconds, and then that pain is gone as soon as the needle is out. So these stem cells have the ability to regenerate tissue, but also stop arthritic processes, stop inflammation. Okay, so where I see so many people who come in and say, well, I went to the surgeon and he said, yeah, you got to have a total joint replacement. I've had patients in their 30s and 40s who have been told that. So big data on total joints. First of all, I would say 95% of the patients that come in to me and say, oh boy, I'm bone on bone. And I said, really? They told you you're bone on bone. Well, let's look at these x-rays that were taken at that office. And I kind of go over things with them. 95% of the time, they're not bone on bone. And the reason that bone on bone is such a widely used phrase, I've come to find out from the insurance companies, is that in order for insurance to cover a total knee replacement, you have to put that in, that has to be in your dictation. So anyhow, surgery itself, it's a big surgery. It's a year of rehab. Um, Oftentimes people do end up going into skilled nursing facilities if they don't have help, because you need help getting around. 65 to 70% of patients are happy with total joint replacements, but 30 to 35% are not so happy, and some are miserable. The pain can be worse afterwards, and then it's an end game. There's nothing else you can do. So I probably see 3 or 4 patients a month who come in because they had a total joint replacement a year or 2 or 5 ago, and they're miserable. They say, oh my God, this is the worst thing I ever did. I ended up with nerve damage. I ended up with an infection. My knee hurts worse now than ever. Can we do stem cells? And I was like, there's, because all you got in there now is metal and plastic. So there's nothing that I can do. Um, some of the potential complications that you get from this, I mean, certainly infection is a big one. Blood clots is another big one, which can travel to your lungs, and then that's a pulmonary embolism. There's some data out there to say that men and women over the age of 60 after a total knee replacement have a 30 times greater for men and 25 times greater for women chance of a heart attack in the year following the surgery. And that's because when you think about it, I mean, we're amputating a joint. There's a lot of bleeding. Subsequently, there's a lot of clotting. And sometimes, unfortunately, some of those clots can make their way back to the heart and the brain. Loosening the knee is going to last us somewhere, but depending upon the activity and your size and your weight, somewhere between 8 and 15 years. Um, there are some studies out there that say that there may be an increased incidence of dementia, and that's in any joint replacement. And that's because of nickel, chromium, cobalt, and titanium that leach into your blood system. And the other thing is, when your body mass index is over 30, all these complications go significantly higher. Um, Total ankles, we don't see near as many total ankles. Some people are not necessarily a candidate for it, like people who have diabetes or any type of peripheral vascular disease, or osteoporosis. And then the same thing goes for the knees and shoulders. If patients have significant osteoporosis, those implants are not going to seat, they're not going to stay there, and they're going to loosen very quickly. And once again, there's a significant amount of postoperative complications from things like total ankles. And then, I mean, the only other option besides stem cells is to fuse the ankle joint, which takes most of the time, takes away the pain, but it also takes away all your motion at the ankle joint. Um, so what do we tell patients before the procedure? Very easy. No anti-inflammatories for a few days before. That means Advil, Aleve, ibuprofen, CBD, turmeric, or any prescription anti-inflammatories. We tell them to drink a lot of water because that just makes the blood draw a lot easier. The only medications that we're really concerned about are chemotherapy. If somebody's undergoing chemotherapy for any type of cancer treatment, and then I end up talking to the oncologist, and blood thinners. So blood thinners, a lot of people are on Eliquis or Xarelto. Oftentimes, if it's okay with their internist or their cardiologist, we'll take them off of it for a day or two. And most of the time, if they have to stay on it, it's not a big deal. We can let them stay on their blood thinner and still do the procedure. It's not a very invasive procedure. Basically, it's a small, tiny little stab incision to do the bone marrow and the liposuction, and then just an injection into the joint. So platelet-rich plasma. Okay, so first thing we do when patients come in is we draw blood. And then that goes through a computer and a centrifuge, and we isolate just the platelets. So it layers out in something called the Buffy coat, and we pipette off the Buffy coat, which is all platelets. And platelets are these great little packages of growth factors, cytokines, exosomes, and ultimately, when used in combination with stem cells, they're fertilizer for stem cells. When used by themselves, they stimulate the body's healing response and ultimately decrease inflammation. Then we do the bone marrow extraction, which I talked about a little earlier. Then we do right kind of in the same, well, kind of in the love handles area is where we do a mini liposuction. And people always say, oh, am I going to be off balance? I'm going to have a dent on one side. No, you don't. We don't take that much that you'll even see that. So then we isolate those mesenchymal stem cells from both bone marrow and from adipose, from fat, because the ones we get from bone marrow are very robust, hardy, long-lived. The ones we get from adipose are prolific. We get tons of them. So that's the gold standard, to do both. We don't do if we talk about blood thinners, we can get around that usually. If somebody is actively undergoing chemotherapy, or if they have any type of blood-borne cancer, or they've got things like leukemia, lymphoma, myeloma, then it's sometimes patients really, really want to do it, and they understand that after I talk to their oncologist that we can't use bone marrow, but we could use fat and PRP. So we can sometimes modify that. And then certainly if somebody has sinus infection or pneumonia or skin infection, we cancel and reschedule the procedure. Okay, unfortunately, there are a lot of people out there, mostly chiropractors and naturopaths. There's some big groups, national groups, that they hire nurse practitioners because they're not allowed to do any of this injections. They buy stem cells online. You can buy stem cells online. I mean, it comes from south of the border. Most basically they sell, or women who want to make some money sell their placentas, and they obtain either amniotic fluid, embryonic tissue, embryonic cord tissue, or something that's called embryonic jelly or Wharton's jelly. It comes like a desiccated white powder, and they just add sterile saline. There are no live stem cells in it, and God only knows what else. And then they have nurses or nurse practitioners do the injections. I have seen some real disasters come about as a result of that, either from here in the United States or people who have gone to Mexico or Panama and had this done. Because the thing that they advertise out of the United States is that they're getting higher numbers because they're getting these stem cells from basically placentas, and but there's no live stem cells in that product. We've had some bad infections that have shown up. We even had one patient who ended up with an above-the-knee amputation after he had it done by a chiropractic group here in Seattle. 3 months, took him to the OR, cleaned his knee out, had a PICC line in him, antibiotics, and it just was not working. So how do people do? What's the results? Patients who have mild to moderately severe arthritis, basically big data says 80 to 85% of patients see at least 80 to 85% improvement. In our patient population, 91% of all of our patients, which kind of that ranges from mild arthritis, meniscus tears to severe arthritis, but 91% obtain at least 75% improvement. So what does that mean? So what basically at 3 months, I always ask the patients, okay, before you came in, let's assume that you were a 10 on a scale of 1 to 10, 10 being the worst. Where are you now? And I want to hear 70, 80, 90% better, so either like a 3, a 2, or a 1. If they're not there and if patients come in and go, yeah, definitely better, but it's like 50%, sometimes we'll just put some more platelets in, which basically is like more fertilizer on the seeds. And oftentimes that can give patients up to about another 20% improvement. And that's something that can be done at any time. I have patients come in at 3, 4, 5 years out and say, hey, it's been great, but I've been playing soccer or hiking and I'm starting to get some more pain. Should we repeat the stem cell procedure? I said, no, we don't need to repeat it. Let's just put some more platelets in. Now, the stem cell procedure can be repeated, however. I had a patient come in the other day, somebody that is a big NFL guy. I can't mention his name, but 10 years ago, it was funny because I walked in the room and right away he looked at me and said, hey, Doc, he goes, do you remember what I said to you when my wife dragged me in here 10 years ago? And I said, no. He said, I looked at you and I said, this is all voodoo. This is bullshit. There's no way this can work. He said, I got to tell you, I've referred over 20 patients to you who've had procedures over these 10 years. Now, including his son, he said, now my knees are starting to bug me. He does a lot of downhill mountain bike racing. He says, I still don't want a total knee replacement. Can we repeat the procedure? I said, yeah, sure, we can repeat it. So he's on his way now. Hopefully he gets another, 10, 12 years out of that. Okay, so I'm just going to skim through a few of these. This is just some data from scientific journals. Some of this is, I gave a lecture to the Washington Academy of Foot and Ankle Surgeons a couple months ago, and some of this is just on ankles, so I'm gonna go through those quickly. These were once again ankles. This is actually, you can see this dark area on the corner of the tail is circled in blue. That's an osteochondral defect that we talked about at the beginning. And this was a guy who had repeat MRI, I think a year or 2 years after, and it showed regeneration of the cartilage and it was completely healed. This, once again, here's a little bigger picture, kind of focused out on that area. Here's the close-up view of before we treated it. And this was still, once again, this is that ankle. So these are just this comes from the Journal of Bone and Joint Surgery, which is an orthopedic surgery journal. There was evidence of meniscus regeneration and improvement in knee pain following treatment with human mesenchymal stem cells. These results support the study of human mesenchymal stem cells for apparent knee tissue regeneration and protective effects. From another orthopedic journal, the Journal of Clinical Orthopedics and Trauma, the versatility of stem cells as a treatment modality has landed it another repair target, osteoarthritis. Through many studies, this newly discovered method has been shown to significantly alleviate the pain experienced by osteoarthritic patients. From Helion, which is a European orthopedic journal, this study shows a single injection of bone marrow stem cells provides long-term benefits. The procedure is simple, fast, well tolerated, avoids the need for hospitalization, and generated no complications or adverse effects. From the Journal of Orthopedic Translation, in contrast to traditional treatments based on drugs, proteins, or antibodies, stem cells are poised to revolutionize medicine as they possess the capacity to replace and repair tissues and organs such as osteoarthritic joints. From Nature, the British Scientific Journal, in conclusion, mesenchymal stem cell treatment improves knee pain, physical function, and cartilage quality without any severe adverse events. Cartilage mapping by MRI shows improvement in good cartilage quality and significant decrease in poor cartilage quality from Mesenchymal Stem Cells and Regenerative Medicine Journal. This is basically stuff I was talking about to the ankle surgeons. The biggest study done, two guys out of Harvard did this about 3 or 4 years ago. They looked at 43 peer-reviewed studies and journal articles and basically kind of did a complete review of all of them. And their, conclusion here is that the duration and efficacy out 2 years from a single treatment, this is of stem cells, greatly exceeds that of any other non-surgical treatment or any possible placebo effect, particularly in light of its excellent safety profile and the absence of other safe, effective treatments for osteoarthritis. AMSCI, so stem cell treatment, should be widely adopted for the treatment of osteoarthritis, and that's out of National Institute of Health. Now there are over 65 million cases done in the US. As long as you use your own cells, it's the only way I do it, there hasn't been a single serious adverse event reported on the FDA database. We use only local anesthetic. The procedure takes about an hour. You walk out, you do need a driver, and we usually start physical therapy the following week. We don't ice. This is rice. The eye should be gone because we want inflammation in that first 6 weeks. So, but rest, compression, elevation. We want people walking. We want people using their shoulders. We want them. So patients get back to activities of daily living very quickly. We avoid anti-inflammatories. We avoid alcohol for 6 weeks. Most people, in the second week, they're starting to spin on a stationary bike and then onto an elliptical, starting to use their shoulders, for more activities. Certainly, most people go back to work the next day, unless, you're a police officer, firefighter, heavy duty construction work, you're a longshoreman, in which case we're looking at some light duty restrictions. And now we actually have physical therapists from MTI, MTI is a physical therapy office here in I say Seattle area, Puget Sound area. They have locations downtown Seattle, Magnolia, actually downtown, and on the east side. And I've known these guys for forever, and they do a fabulous job. And I think one or two of them is going to come and talk about the physical therapy afterwards. And then I'll be back on. You guys can type in questions, and I'll come back and Chelsea will read me those questions and we'll answer all of those.
The chance to be here tonight. Just a little bit about me by ways of introduction. My name's Matthew Wood. I'm a physical therapist with MTI Physical Therapy here in Seattle. We have several clinics around the Puget Sound area, and I'm actually the manager of our First Hill location. I'm a board-certified orthopedic clinical specialist and a fellow of the American Academy of Orthopedic Manual Physical Therapists. Dr. Wagner and I have actually collaborated on the care of several patients as they've gone through this regenerative medicine process. I'm here to speak a little to the rehab side of the process and where PT fits in after stem cell therapy. Many patients who seek regenerative medicine have been in pain for a while, and so that makes PT important in the rehab process because that's why Dr. Wagner almost invariably refers for PT after an injection. PTs analyze someone's motion and actually their process of motion as well, and they identify any areas of challenge, and then we'll apply an individualized intervention to help address any of those challenges. Some of those challenges include too much or too little motion, weakness, poor joint coordination, or sometimes it's even something like an inability to bear weight or to transfer force. And my understanding is, in essence, the regenerative medicine process aims to help you use a body structure more easily in a more pain-free manner. So that's whether that be a joint or a ligament or a tendon. And so what physical therapy does in that process, therefore, is that we help protect, guide, and then reinforce that new usage. Finally, we take you through a process of increasing your tolerance for those activities that a patient wants to get back to doing. And so that's the fun part. That's the return to play part. So what that looks like is if a patient who comes in after regenerative treatment, our chief goals are listed here. We want to protect the treatment tissue. We want to maintain motion and improve motion at the other joints or tissues further distal from the involved joint. As Dr. Wagner said, there is inflammation is part of the process of the regenerative medicine. So therefore, we want to make sure there isn't too much motion or shearing force at the joint. And we want to make sure that the patient understands that just how much really to load that tissue. And depending on where the tissue is, that changes. Like we're gonna change things depending on whether or not the injection site has been a thumb or a carpal metacarpal joint or an ankle. We try to minimize the effects that irritable tissue can have on the rest of your body, and we can start getting the other parts of your body which have contributed to or compensated for that original injury. We want to get those parts moving properly. So that includes releasing any muscle tension, sometimes joint restrictions further away from the involved joint, and activities like core strengthening. So a good example of this might be after regenerative treatment to the knee. We train both the hip and the ankle in such a way that it doesn't affect the knee joint directly. But what it does do is it minimizes the forces that then your body during those activities of daily living will be transmitted into that knee, and that happen as a result of just normal motion through the rest of the leg. This then allows us to start the next phase, which is when we start to efficiently and progressively load the joint or the tissue in question. So what we're doing here is we're hoping to improve appropriate use of the involved structure, both individually. So, in the case of a knee joint, we want to strengthen the muscles local to the knee joint and as part of a unit. So that would be, how do we effectively load a flexed hip, knee, and ankle unit? So we're strengthening both the structure and the region. We address balance deficits, and we continue to ensure appropriate loading of the tissue that's been treated under the instruction or under guidance and consultation with Dr. Wagner or the referring physician. While we do have guidelines for this, how long each of these phases, the first phase is pretty cut and dry. That's 4 to 6 weeks through that inflammatory phase. But the secondary and tertiary phases can last, can be variable because it depends on how long the impairments that we're addressing have been hanging around. So if someone injured their knee 3 weeks ago, sought care immediately after that, sometimes this mid-stage progression can operate a little more quickly. If you are operating, or if we're working, with an arthritic knee that's been painful for decades, sometimes this phase can last a little longer as we have to address a lot of those impairments which led us, to the process of regenerative medicine in the first place. After we're confident that the tissues can efficiently take and transfer load and with minimal pain, that's when we start moving towards more functional goals. So that's working on getting patients back to doing what it is that they love by focusing on power, speed, strength, and moving three-dimensionally in space rather than just, what we call a uniplanar or a biplanar motion. So that's a very broad stroke approach to rehabilitation after regenerative therapy. We can get a lot more granular, but with a skilled physical therapist, it's their job to evaluate the patient that's in front of them, and to walk through that process with the patient. So there's always that process of continual analysis and refinement that we do with these interventions and with our assessments that make sure they best fit the patient and then also best fit the regenerative medicine process. So I'm happy to stick around and answer any questions that may come through, but otherwise it's time to throw back to Dr. Wagner.
Thank you, Matt. I appreciate that. And I'll just tell everybody, these guys, they know everything there is to know about rehabbing, not just stem cells, but I've been sending patients to MTI for literally 30, 35 years, and patients love it there. They do a great job. So I think now we'll open it up for questions. I think Chelsea has them, and she'll just read me off some of your questions. I'll go ahead and answer those.
All right. So first question. Severe hip osteoarthritis has osteophytes, and they've been dealing with pain and mobility limitation for over 20 years. Would you recommend stem cell in that case?
So the osteophytes don't really bother me. Those are typically on the periphery of the joint. They're not within the joint. It all depends what the joint looks like. And so basically, if the range of motion is still pretty good, if you're, fairly healthy, then, I mean, you might be a good candidate. Certainly, it's certainly worth a consultation to see, because if I look at it and I say, oh boy, it's maybe you're only sitting in that 50-60% category of getting better, then it might be, I might say, I might refer you to somebody for a hip replacement. But it certainly at least a consultation to see what's going on, and then we can have that discussion.
Someone said that they wanted to know about options for spinal issues.
So I have that's something that you could call the office. I do have some people I know who do a very good job in spine, and we can give you that contact information.
Someone asked if you inject fingers.
We do fingers. Most of the time with fingers, we do platelets, PRP, because those small joints, it's hard to get stem cells in them without damaging them. And most of the time, we don't need to do stem cells in fingers. We just do the platelets. So fairly simple.
Someone asked, generally, how long is the physical therapy for a meniscus repair of the knee?
So typically, you're young, healthy, you have an otherwise normal knee, you just have a meniscus tear, maybe twice a week for 3 weeks, and then kind of, getting back to a return to activity program.
Yeah, I think Matt maybe be able to answer that one too.
Yeah, what do you think, Matt?
Again, it depends very much on the nature of the condition that we're dealing with. But certainly, again, like, as Dr. Wagner said, we're talking young, healthy. Then once the irritability of the knee is brought down, or comes down depending after the stem cell process, then when the patient's young, that's a relatively quick and easy rehab. I'd probably add a few weeks to that, so I probably wouldn't say 3 weeks, but maybe closer on 6, but 6 to 8 weeks. And then again, if we're dealing with chronic meniscal tears, then we deal with someone who's probably been compensating for those for a while. So we add a little bit of time to those, simply because once you've had a painful knee for 3 to 6 months, it doesn't matter how good your pain tolerance is, your body's going to start to compensate and move around that. And so therefore, that's when we want to make sure that when we're doing a really good job, we take into account the ankle, we take into account the hip, as well as addressing the knee itself through that process.
That's why these guys are so good. I mean, a lot of times getting patients back, I have everybody, they want to get back to running, but if it's been a long time, they develop front to back, side to side imbalances, they get atrophy, they change their gait, and if you just say, okay, go out and start running, may end up with another issue. Looking at gait analysis, things like that, and kind of the whole picture is what they're so good at doing. So.
Okay, the next question, there's a few of these, wondering about insurance coverage and cost.
Okay. Unfortunately, no insurances cover the procedure itself. I do with a lot of professional athletes, they do end up getting it covered, but that's a different story. The people can use, like, if you have a health savings account or flexible spending account, you can use those type funds. Cost basically anywhere, whether it's a small joint or a large joint, is anywhere from like $4,000 to $8,000. And if you do multiple joints, it's basically, so say you do one knee, could be any large joint would be about 8,000, whereas if you do two, it's about 11. So it does save you, quite a bit if you do the two joints at the same time.
The next one said they had a partial rotator cuff tear for over 20 years. Can stem cells help repair the joint?
Definitely can. We see a lot of those because they can be degenerative tears, they can occur over time and they get worse over time. And sometimes there could be some labral damage going on inside the shoulder joint. And these are people who are like, it keeps me up at night. I have pain. I turn onto my shoulder. It's starting to affect my golf game, or when I'm swimming, I'm getting pain. And they do incredibly well with biologics.
Someone did say that they were shot in their back twice and a bullet is stuck in their lower back, making them paralyzed. Do you have any idea on that one?
I have had a number of patients, actually a couple that I can think of were good friends of one of my son, who was mountain biking. And what happened? I know. They were going off some jump at this mountain biking park over by Snoqualmie. And at the last minute, he kind of tensed up and thought, shoot, I don't want to do this. He ended up going head first, having a cervical spine injury, being quadriplegic. His dad called me. He was at Harborview and just said, God, do you know anybody who does, spinal cord injuries? And actually, I referred them to a couple people, one lady at University of Texas in Austin, who's a neurosurgeon who does spinal cord stem cells. Um, I see the boy every once in a while. He's doing great. He still is basically paraplegic, but he has regained the use of his upper body, which was huge for him. But I know there's a lot of research being done in spinal cord trauma with stem cells.
Someone asked that you mentioned labrum tears in the hip are difficult to get to. How about shoulder labrum tears?
Shoulder, I mean, you can get to them surgically. It's just that oftentimes people can end up with postoperative stiffness. And then there's a reason that you have that labrum there. You don't want to just trim it and take it out, if you don't have to. So if you can repair them and leave them there, that's the ideal situation.
Someone said, can stem cells work on complex tears in a meniscus?
Oh, absolutely. We do those all the time.
Is an X-ray enough to see the joint, like a knee, to recommend stem cell, or is an MRI better?
Maybe. So if somebody's got significant arthritis that it shows up on an X-ray, then there's no need to get an MRI. If somebody comes in and I take an X-ray, I go, your knee looks pretty normal, let's get an MRI because I don't know exactly, is it a meniscus tear? Could it be some osteoarthritis that it's not prevalent enough or significant enough to see on an X-ray? So that's when we'll do MRIs. And then when we do MRIs in the hip and the shoulder, it's important most of the time to put dye in those two joints because it gives us so much more information on labrum and rotator cuff tears if we have the dye in there.
Someone asked, how do you know that you have a sufficient source of stem cells to harvest?
You wouldn't be walking and breathing if you didn't, because somebody at MIT did a study on stem cells, kind of this whole physics and mathematical computation, and that if your body stopped producing stem cells, and I can't remember if it was 2 minutes or 20 minutes, but that's how long you'd survive. Because you're constantly regenerating tissue in your body and you need those stem cells. So everybody, unless you have, it's like some kind of aplastic anemia or total bone marrow failure, in which case you're not going to be walking into my office for a procedure. You're going to be in intensive care. Everybody, like I said, I've got two patients who are 103 that we've done, and people still have pockets of areas that we can get significant amounts of cells.
Someone asked if they could use a physical therapist that is close to them after the procedure.
Sure. We want you to because I want you to be compliant. I don't want you to drive down here to do physical therapy. We have patients all the time. Literally, I was telling my son, younger son, the other day, I said, we've seen patients from every continent in the world. He said, wait a minute, Dad, what about Antarctica? And I had to think about it for a second, but we did see a teacher who was stationed in Antarctica teaching kids up there. But Yeah, basically, so we find physical therapists in India and Jakarta in Europe, and we have patients see the physical therapist there. And if they're local here, we have great offices to refer them to. Um, but if they're in Bellingham, Eastern Washington, Alaska, we know we have a huge network of physical therapists that we will recommend.
Someone asked how many treatments does it take?
The hope is one and done. We just do it one time. Sometimes we'll put some more platelets in if we need to, which is 15 minutes. It's not a big deal. But that's only if we're trying to kind of ramp up activity of stem cells.
Someone said they're considering stem cells for their knees. They have a friend who had them injected 6 weeks ago. The joint's still sore after sitting, sometimes low or no pain. Had cortisone shots before deciding on stem. Is it normal or should inflammation and pain be mostly gone by about 6 weeks?
So most of the time at 6 weeks, although patients may not necessarily be experiencing improvement yet, they're usually not swollen, stiff, sore at 6 weeks. Um, I tell patients usually 6 to 12 is where you're going to start to see improvement. But I have some people, and I can't explain it, but who say, doc, the next day, I was like, oh my God, this is the best it's been in 15 years. I don't know, I'm sure a lot of you guys out there know who John Curley is. And John, I did John's hip, and he had pretty significant arthritis in his hip. And then I heard him on the radio, and he said, I went to see Dr. Wagner. He goes, a week ago, and my hip is feeling great, and I'm going to go out and go for a run. And I just kind of said, Jesus, John. I said, don't go for a run. Remember we talked about this 6 weeks, but now he's back running 5Ks and doing great. So it varies tremendously on how people do. I've had some people who at 3 months even they're like, it just didn't do anything. And then I had a guy stop him. I wasn't even here. He left me this handwritten note to tell me that he's in his 70s. He says, I got to tell you, it took 6 months to a year, but I'm hiking 15, 20 miles on the weekends with 20-year-olds and 30-year-olds, and I have no pain in my knees whatsoever. So it can vary quite a bit.
Someone asked, how effective are PRP or stem cell procedures in small joints with osteoarthritis, like the hand?
Well, I can give you a personal story right here. This is called the first CMC joint in the base of the thumb, kind of almost into the palm of the hand. I've got significant arthritis in that joint. It just runs in my family, my mom's side of the family. And 10 years ago, I mean, I was like, I'd be assisting in the OR and I was like, oh my God, this is the worst in the world. I couldn't, playing tennis was miserable, fly fishing, planting ski poles. So I had somebody inject cortisone, one of my partners inject cortisone. And if I was lucky, I got 2 or 3 weeks of relief. So finally I said, hell with this. I had one of my buddies at Stanford do stem cells. That was 10 years ago. And I mean, do I get a little bit of pain? Yeah, if I'm moving, like helping my kids move to a new house or apartment with heavy stuff, I do get some aching, but it does not stop me. I can ski all day long, planting poles. I can fly fish all day and have no pain in my thumbs. So that's where it works really well at the base of the thumbs, and also where people get bunions and their big toes. But we inject the midfoot, when people have osteoarthritis there, and we get very creative with some small joints in the feet, and certainly in the wrists. We do a lot.
Do you have an option to do the stem cell procedure with full anesthesia instead of just local?
We do not. We're not an ambulatory surgery center, so we don't have anesthesia here. It would really prolong the length of the procedure and the cost as well. So that we just do it we do give patients, medication. We pre-medicate them with pain meds and anti-anxiety medications if they need it. We use ropivacaine, which is a local anesthetic. And most people do just fine. I mean, it may be the bone marrow can be, like I said, for some people, it could be like 30 seconds of pain.
There's a few questions asking about insurance companies covering like MRIs or X-rays, or is that included in like the cost of the consult, things like that?
So insurance companies cover the consults, and they cover, we get certainly they cover their x-rays, which we do here in the office. MRIs, basically, we get in usually the facilities that we use to do MRIs get a pre-approved first through the patient's insurance, and so that takes a couple days, and yeah, they're usually covered.
If this is a superior treatment to joint replacement, why doesn't insurance cover it?
There's a lot of politics involved in that. So orthopedics departments in general run hospitals because they bring in the bucks. They keep the lights on. So, total joint procedures are very expensive procedures, and they, basically fund hospitals other than places like Fred Hutch and Seattle Cancer Care. So there's a huge lobby of ambulatory surgery centers and surgeons and hospitals who don't want to see those total joints go away. But if you look at places like Mayo Clinic, where I was just back at Mayo a month ago, Cleveland Clinic, Johns Hopkins, Harvard, Stanford, Jobe, Stedman, all major orthopedic centers in the country, they're all doing stem cells, because they work. And those places are not dependent on, just doing these big surgical procedures. So that's basically, why we don't see it get covered by insurance.
Along that same line about kind of insurance covering the physical therapy portion.
Yeah, I mean, Matt, you probably see you guys get good insurance coverage for PT, right? I mean, I've not heard any issues there.
It very much depends on the patient and the insurance and the physical therapist. There are some offices which will accept every insurance. There are some offices which will be a little bit more sparse about which insurances they'll accept. So there, unfortunately, it is a little bit of a case-by-case basis. With that said, if you have an idea about which physical therapy office you would prefer to use, if you've heard, be it MTI or be it someone that may be a little bit more local to you, if that's Jakarta or Bellingham or even Everett, then certainly it's probably a good idea to check in with that physical therapy clinic before or in the process of making appointments, just to make sure that you are covered.
Someone asked, is there a nutritional or therapeutic regimen to increase the production of stem cells in older patients?
So the only thing I tell patients is don't, sometimes we have people come in, or I get a lot of referrals too from orthopedic surgeons. I've been around here forever, and I know, most of the guys here. So I'll have patients that come because they're not candidates for total joint replacement. Maybe they've got significant cardiovascular disease or diabetes or osteoporosis, or they're obese, and they'll say, go see Wagner for stem cells. And, in those cases, I'm trying to think, what was the initial?
Is like are there nutritional
regimens?
Or
so that's right. I was thinking about patients who are obese and they go, well, should I go on a crash diet? No, those cells need nutrition. So we tell people, no, don't go on these crash diets. Ultimately, after the first 6 weeks, it's okay to kind of go on an anti-inflammatory diet, a Mediterranean diet, or avoiding a lot of simple sugars and nightshade vegetables and that kind of stuff. But otherwise, we do start people on something called Synovitis, which is very high dose hyaluronic acid. It's the building blocks of cartilage, and it's a supplement that you take twice a day. I usually tell people take it for at least 6 months. And then we have a lot of people who just stay on it. I've been on it for 9 years, probably. So yeah, but other than that, there's really no specific nutritional aspect to it.
Someone asked if we treat carpal tunnel syndrome.
We do treat carpal tunnel. What I do for carpal tunnel is PRP, though, because I'm not trying to regenerate anything. I'm just trying to decrease inflammation in that tunnel that surrounds that median nerve. And so that's basically a 15, 20-minute procedure of just injecting the platelets.
Someone asked what the advantage of stem cell over joint replacement is for arthritis, specifically in the fingers.
joint replacement in the fingers, basically involves putting in, plastic, and I think the silastic implants that they use for those. I mean, certainly PRP procedure, you're looking at an injection that takes a couple minutes as opposed to a surgical procedure. I guess it depends how bad and how dysfunctional that joint is.
Someone asked if there's any recommended next steps in younger patients who report like no significant changes in their pain a couple of years post-procedure.
Well, I mean, then we have to look at other things. I mean, maybe somebody had a meniscus tear that just didn't respond to stem cells, and maybe we need to go in with a scope and trim that up. Maybe somebody, I mean, I hate to send people for microfracture surgery just because I don't see great results with it in young people, but that is sometimes, an option. And certainly, surgery or joint replacement if it's really bad, but it all depends on age. I've got one guy right now who's, what is he, 34, and he's done stem cells twice. He's definitely better, but he's like, Doc, I can't run the bases. I can't do anything. And no, I've sent him to a couple of the surgeons, and they're like, at 34, the problem is this guy wants to be active. That knee's going to last him, maybe it'll last him 10, 12 years. Then we got to do it again. And each time you have to do a revision, the results aren't as good. And the implants, the stem maybe not seed as well or hold there. So yeah, it can be a tough problem, but it's something we take on a case by case basis and see.
Someone asked if they have uncomfortable osteoarthritis in their knee. Would it be recommended to try PRP first or to do the stem cell procedure?
If it's osteoarthritis, you probably want to do stem cells with the PRP. PRP by itself can give you good results, but usually it's going to be limited to about 6 months. Because PRP by itself only decreases inflammation. It doesn't necessarily regenerate tissue.
And someone asked if this video will be available for viewing later. It will be on YouTube, hopefully tomorrow. And I don't have any other questions, but if there are any other questions, please feel free to submit them.
Yeah, anything you guys have, and you can always contact our office with email or give us a call as far as questions or consultations. We can usually get people in within a week or two. And then oftentimes we have people who, are all over the world, and what they'll do is they'll send us their images, and then we'll do telemed. We can do it on Zoom or whatever. And we have people, those people flew up today from Southern California. Some people who, yeah, they flew up from, so they met my cousin who I did her knees as a neighbor of theirs. And so they did a telemed, and they flew up. The husband flew up first and he did his knees, and the wife flew up today and did her knees. And then they just jumped on a plane and flew back, and they're doing physical therapy in San Diego or wherever they live. And so yeah, that can be easily done on telemed or Zoom consultation.
Last question, it looks like, is seeing you for a consultation the same as an ortho doctor?
So I do non-surgical orthopedics, and I'm not gonna do a total knee replacement. I'm not gonna do a surgical procedure. However, if I feel that you're not a good candidate for biologics, I'm going to refer you to an orthopedic surgeon who I trust to consult on a hip or a knee or a shoulder replacement.
And then there was just a patient or a person that joined that said that he wanted to thank you, all of us, for being generous with your time.
Okay. And thank you, Matt. I appreciate you hanging out and doing this.
It's fun to be here. Thanks for having me.
All right. I'm going to go catch the rest of that Gonzaga game, which has started 10 minutes ago, I guess. So we'll see. All right. Thank you, everybody, for joining in. And like I said, if you have any questions, this will be online. I think you'll get something in your email as well with the information. And you can always shoot us emails or give us a call for questions.